700 years ago, psoriatics were burnt at the stake. The scaly eruptions of psoriasis, named from the Greek to itch, were grouped by Hippocrates with leprosy. For 2 millennia, psoriatics and lepers shared the same fate. Even Robert Willan, who first truly classified psoriasis in 1809, failed to distinguish it with certainty from leprosy. Later in the 19th century, a series of accurate clinical, histological and etiological expositions established the salient features of the disease, but came no closer to producing a cure. In fact, the spontaneous remissions characteristic of psoriasis hindered therapeutic advances and engendered an eclectic approach to treatment. Effective anti-psoriatic drugs have emerged on an empirical basis. While all share a broad anti-inflammatory or at least anti-mitotic effect, they differ substantially in their modes of action. For this reason, their use has furnished few specific insights into the pathogenesis of the disease. Instead, the impetus in clinical development has been to refine the pharmacology, presentation and tolerability of established generic groups of anti-psoriatic agents, such as coal tars, dithranols and corticosteroids. In 1978, the clinical introduction of cyclosporin, a potent inhibitor of T-cell activation, revolutionized renal transplantation and opened the doors to liver, heart and lung transplants. An unexpected benefit of this innovation transformed the clinical perception of psoriasis. Cyclosporin cleared psoriasis in psoriatic transplant recipients and patients treated for arthropathy. Since the early 1980s, these isolated clinical reports have been verified in thousands of psoriasis patients. Acceptable systemic levels of 5 milligrams per kilogram cyclosporin induce remission over a period of 6 to 12 weeks in approximately 60 to 70% of patients. Studies of higher doses have been frustrated by serious side effects. Even the lower levels cause nephrotoxicity and hypertension in some 10% of patients. As a result, the clinical use of cyclosporin is now usually limited to the treatment of severe or refractory psoriasis. The efficacy of cyclosporin did, however, substantiate the role of the immune system in the pathogenesis of the disease. Following microbial infection, an immune response is normally elicited by bacterial or viral antigens when presented in association with specific histocompatibility or HLA molecules on the surface of host immunocytes. These HLA antigen complexes are recognized by circulating T cells, resulting in their activation and proliferation. HLA molecules are encoded by polymorphic genes in the major histocompatibility complex, or MHC. Each individual inherits a characteristic set of polymorphic HLA genes, known as their HLA haplotype. Particular HLA haplotypes are associated with diseases of previously unexplained etiology, such as ankylosing spondylitis, insulin-dependent diabetes, and multiple sclerosis, suggesting that some HLA molecules can activate T cells inappropriately, causing an autoimmune response. The HLA associations of psoriasis, now known to be a formal genetic linkage, are among the strongest of established autoimmune diseases, although weak in comparison with ankylosing spondylitis, the archetypal autoimmune disease. Moreover, different phenotypic expressions of psoriasis, such as chronic plaque psoriasis or psoriatic arthropathy, exhibit different HLA associations. Despite these strong HLA associations, the proportion of individuals carrying the implicated alleles who actually develop the disease is just 10%. Clearly, other factors must be involved, which could be either environmental or genetic. Compelling epidemiological evidence demonstrates that additional non-MHC-linked genes are in fact involved. The existence of a rare nevoid form of psoriasis suggests that at least one of these psoriasis genes must be expressed in the skin rather than in circulating immune cells. Nevoid eruptions are histologically and clinically indistinguishable from chronic plaque psoriatic lesions, but exhibit a unilateral distribution along the lines of Blaschko. Such a mosaic cannot be explained by systemic factors alone, because these should not produce localized involvement. But are disparate forms of the disease, such as chronic plaque, pustular, or guttate psoriasis, associated with different non-MHC-linked genes? Or are the same genes responsible for all forms of the disease? While psoriasis gives every appearance of heterogeneity, a string of clinical observations suggests that the same genetic mechanisms do underpin all cutaneous forms of the disease. For example, all forms display similar responses to a broad range of drugs. All are susceptible to the Koebner reaction. All exhibit comparable profiles of associated clinical features, such as arthritis and nail changes. And all display histological features of the psoriatic process. Moreover, it's likely that a single patient will suffer from diverse forms of the disease over a period of years. It seems that the entire skin of psoriatic subjects could be prone to disease, and that uninvolved skin may be abnormal. But in which skin cells are the proposed genetic defects expressed? Recent molecular biological and immunohistochemical evidence implicates epidermal keratinocytes as the key players in all forms of the disease. On activation, either by T cells or other factors, the psoriatic keratinocyte releases cytokines, stimulating the activation of adjacent keratinocytes. This results in the expression of intercellular adhesion molecules such as ICAM-1 and chemotactic factors such as interleukin-8, leading to the recruitment, adhesion, and activation of self-reactive T cells. Activated T cells release more cytokines, causing further keratinocyte activation. It is thought that the genetic defect in the psoriatic keratinocyte may precipitate an abnormal proliferative and inflammatory response to cytokine stimulation. But the precise molecular mechanisms are yet to be defined. It is clear, however, that the ideal anti-psoriatic agent should specifically modulate not just T cells, but also keratinocytes, thereby suppressing the hyperproliferative response to cytokine stimulation. Vitamin D, which was found to have a positive effect on psoriasis as long ago as 1936, may do just this. The role of vitamin D in calcium homeostasis and bone mineralization has long been recognized, but its possible importance in cutaneous physiology came as a surprise. It is now known that vitamin D is produced in the skin from 7-dehydrocholesterol on exposure to sunlight. This may play a role in some geographical, cultural and seasonal variations in psoriasis expression. The vitamin D receptor is constitutively expressed in keratinocytes of all epidermal layers, except those of the stratum corneum, and in cells of epidermal appendages. In addition, 50 to 70% of Langerhans cells, monocytes, and T lymphocytes in the normal skin express the vitamin D receptor, in contrast with circulating B and T lymphocytes, which must be activated before expressing the receptor. The active metabolite of vitamin D, calcitriol, binds with high affinity to the vitamin D receptor, a member of the nucleosteroid receptor family, inducing both transcriptional and cytoplasmic changes. These changes appear to modulate the expression of key cytokines and proto-oncogenes at both protein and mRNA levels. Changes in cytokine expression induce terminal differentiation of keratinocytes and suppression of the immune and inflammatory response. In terms of its specificity and mechanism of action, at least in vitro, calcitriol exhibits many properties of the ideal anti-psoriatic agent. Unfortunately, the severe calcemic effects of high plasma levels of vitamin D, which may cause extensive calcification of soft tissue, mitigated against the therapeutic use of calcitriol after early success in the 1940s.
Okay then, now if you'd just like to hold still for me.
Interest was not revived until the chance observation by the Japanese clinician Morimoto in 1986 that calcitriol cleared psoriasis in a patient treated for osteoporosis. Numerous analogues of calcitriol, which separate the cutaneous effects from the classical hypercalcemic effects, have since been synthesized. Calcipotriol is so far the best studied and most successful of these analogues, with a similar vitamin D receptor affinity to calcitriol, yet up to 200 times less calcemic. Pooled data from clinical trials show that if used as indicated, topical calcipotriol has no clinically significant hypercalcemic potential, even when used daily for periods of 12 months or more. These studies also showed that calcipotriol is generally well tolerated, with the majority of adverse events being mild and transient local skin reactions. In terms of efficacy, calcipotriol is a valuable addition to the dermatologist's armamentarium. Large-scale parallel group trials comparing topical calcipotriol therapy with two established anti-psoriatic regimens, dithronol and the potent corticosteroid betamethasone 17-valorate, demonstrate convincingly that calcipotriol is at least as effective as these agents. At an optimal concentration of 50 micrograms per gram, calcipotriol therapy reduces the average psoriasis area and severity index by 60 to 70% over 8 weeks, producing marked or complete resolution of plaques in up to 90% of patients. Therapy can be continued successfully in combination with emollients for periods of a year or more. Residual erythema may be resolved by combining calcipotriol therapy with a corticosteroid, which may act as an immunosuppressant with a direct effect on immune and inflammatory infiltrates, or more simply, as a vasoconstrictor. For example, 12-hourly alternating regimens of calcipotriol with the potent class 3 corticosteroid betamethasone valorate is significantly more effective than monotherapy alone. The cutaneous side effects and unpredictable relapses associated with potent corticosteroids are significantly ameliorated by combination with calcipotriol. Similarly, the incidence of transient irritant skin reactions associated with calcipotriol itself is reduced by combination with corticosteroids.
Okay.
Severe, refractory or disseminated psoriasis, typically requiring photo or systemic therapies, also respond better to combination with calcipotriol than to monotherapy alone. For example, combination of calcipotriol with UVB or PUVA reduces the dose and number of phototherapy sessions required to clear psoriasis, lowering the risk of cancer. Similarly, combinations of calcipotriol with the potent oral retinoid acitretin or with cyclosporin are more effective than respective monotherapies and attenuate the dangerous side effects of these drugs. A cure for psoriasis awaits identification of the exact genes involved. In the meantime, anti-psoriatic therapies have advanced to the point where psoriasis can be cleared quickly and cleanly in most patients. For treating severe, disseminated or refractory psoriasis, methotrexate, cyclosporin and PUVA remain appropriate, despite their side effects. For the majority of patients with chronic plaque psoriasis, calcipotriol is increasingly recognized as a valuable and well-tolerated therapy. In combination with other agents, this role may be expanded to other forms of the disease, increasing efficacy, reducing the risk of side effects, and controlling spontaneous relapses.
Patches of steel.